Okay, so as people are arriving, I want to welcome you to the session of the AGE-WELL EPIC Conference, to the session of the AGE-WELL EPIC Conference 2024. My name is Josephine McMurray. I'm an older white woman with short curly brown hair, and I'm wearing a gray turtleneck if you have any visual issues. And I go by the pronouns of she, her. I'm an associate professor at the Laurier School of Business and Economics at Wilfrid Laurier University and an associate scientific director at AGE-WELL. I have a number of research domains of interest, some of which intersect with the subject material for today. And in particular, we're looking at folks who are workers, older workers who have mild cognitive impairment identified while they're on the job. And we're looking at building accessible workspaces for them. Today, I'm broadcasting from the shared traditional territory of the neutral Anishinaabe and Haudenosaunee peoples. And this land is part of the Dish with One Spoon Treaty between the Haudenosaunee and Anishinaabe peoples and symbolizes the agreement to share, protect our resources, and not to engage in conflict. So in addition to my short introduction that will be coming today, we're excited to have two EPIC presentations as part of today's session, one by Carrie and one by Farah Tahsin, and a Moving the Dial presentation by Chenny Xia of Gotcare, from Gotcare. So before we begin, I'd like to just sort of note that the 4 EPIC conference sessions took place last week, and they continued from Monday to Thursday this week. We encourage you to view the recordings of all the sessions. Check out the AGE-WELL EPIC Conference webpage to download the EPIC Conference program, which will include details of each of the challenge area sessions. So for those of you who are not as familiar with the challenge areas, early in our organization's history, we conducted an extensive review and public consultation process across the AGE-WELL network and with its members, its partners, older Canadians and caregivers. And we identified these 8 challenge areas that make up Canada's future research and innovation agenda in technology and aging, as well as the backbone for AGE-WELL's activities moving forward. And that's the reason why we actually use this. There is some science behind it. So these challenge areas are not just about problems, though. They're also obviously about opportunities. And that's what we're here today to discuss. And the opportunity we're talking about today is financial wellness and employment. And we're going to, again, as I mentioned, we're going to have the research presentations. We'll have a 5-minute Q&A following each presenter, as well as following the Moving the Dial presentation. And then we'll kind of have a general Q&A at the end of that. That will be your opportunity as the audience and our conference attendees to contribute to an overall discussion that places the presentations in a larger discourse, we hope, about potential research and potential real-world impact of the researchers who are present and an entrepreneur who's presenting today. So all of you are encouraged to use the Q&A box that's at the bottom of your screens to ask questions. You can leave a comment on a question, or you can upvote questions that others have submitted. I just want to mention that the session is being recorded and will be available for playback, and links to the playback will be posted on the EPIC Conference website and the AGE-WELL YouTube channel. So today they asked me to give just a quick intro. I'm going to try and make this really, really quick, but just to sort of give a couple of the reasons why we should care about older adults' financial health and employment. And for the first time in Canada's history, there are now more individuals over the age of 65 than there were children under the age of 50. And we all know that. We know that by 2036, almost half of the population will be 55 or older. And of course, as the population ages and more individuals exit the workforce, this can put pressure on labor force growth, and that can oftentimes sort of impact economic growth. But it will mean that Canada will be really relying heavily on productivity and increased workforce participation of all Canadians. So this has implications for us as older adults and for the population as older adults, both individuals and our concerns about how we improve our lives as we age. So what we know is that labor force participation rates for older adults are actually rising. So Canadians 55 and older are working longer. You can see back in the 76, everybody was buying into the Freedom 55, and that started to change for a number of different reasons, both economic, preference, and sometimes pressure, financial pressure. And what we're seeing is that many retired Canadians are actually working part-time or they're self-employed. But older adults face a number of unique employment challenges when they stay in or they re-enter the labor market, and our participation rates lag behind those of other countries for some and other reasons. The issues of workplace ageism, disincentives or lack of incentives to work once you're receiving retirement income, difficulty finding and applying for jobs, lack of education and access to training, and the lack of workplace accommodations related to both those who are working with health issues or who just want to have greater work-life balance can prevent people from actually entering or staying in the workforce as an older adult. When it comes to your financial well-being, it's determined by a number of different factors. Kempson, Finney, and Pott put out this research back in 2017. Financial behaviors, things like saving and borrowing, can impact your financial welfare. Social factors like age, employment status. Psychological factors, things like your confidence or, attitudes toward money. Your economic factors, like your income accumulated over your lifetime or currently. And then, of course, your financial knowledge and experience. Your self-confidence and experience with financial products. All of those can actually impact on your financial well-being. And what we know is that older Canadians can actually achieve higher levels of financial well-being. They're oftentimes more financially secure. They tend to have strong financial confidence. And they are more than others in the Canadian workforce. They tend to have the ability to cover unexpected expenses. So they are doing well. But we also know that there is a 6 to 7% poverty rate. And in this particular study by the Government of Canada, 18 to 24% of Canadians who said that they were either struggling somewhat, were older Canadians. So this issue of financial wellness is really important and something that we need to consider when it comes to how we can help people to gain that financial confidence and to improve their lives as a result of better financial well-being and potentially extend their employment life if they wish to. So I'm going to hand over now to our research presenters for today. Our first presenter today is Carrie Dye. She's an NSERC postdoc fellow at the Department of Computer Science, University of British Columbia. Her research lies in the field of human-computer interaction with a specific focus on aging, dementia, and accessibility. Her current work aims to improve the cognitive accessibility of financial technology to better support older adults, people with dementia, and their families. She's looking at potential design space for AI-mediated family and community support in online banking and digital payments. Before joining UBC, Carrie completed her PhD in information studies at McGill University. So Carrie, I see you've shared your screen. Thank you so much. You have 10 minutes. I'll monitor the Q&A box for you. So audience members, feel free to post the questions as they arise throughout Carrie's presentation, and we'll get to them at the end of the presentation. It's over to you, Carrie.
Oh, thank you so much, Josephine, for the lovely introduction and overview of the entire research landscape around fintech and aging. And I'm really happy to be here to present my research in designing cognitively accessible financial technology to support older adults. This is my postdoctoral research funded by AGE-WELL EPIC-AT and the NSERC postdoctoral fellowship. So the two major motivations for this work comes from my PhD research and my internship. During my PhD years, I have looked at supporting people with dementia in community social programs. During the process, I engaged in a range of community-based activities for people with dementia, their family caregivers, and the professionals working in this space. And recently, I completed an internship with the Bank of Canada, helping them doing literature survey on the universal access of digital currencies. So these two avenues led me here to look at the cognitive accessibility of financial technologies. So let's dive right in. Financial technology, as we call it, Fintech, has grown ubiquitous with increasing online services and declining cash use. Like, we need renewed efforts to ensure continued barrier-free participation in this financial aspect, which is fundamental in social inclusion and activities. I am sure we all have relatable stories or situations around us. For example, older adults use credit card and cash very frequently, but maybe during the pandemic, some places no longer accepted cash, and some older adults started using mobile banking apps or online banking during the pandemic. While some of them might not fully trust banking apps, will still prefer to receive paper statements or bills to view their transactions. And sometimes when running into problems, they might just choose to go to a bank branch just to resolve the issue. We could also think older adults typically face with complex financial management situations with a lot of accounts for personal use, for family, and sometimes even for the business, because as Josephine mentioned, people work longer now, people retire late. So very likely people are juggling both the personal and the business side of the financial management. And also, as we age, we face the cognitive decline. Sometimes it's dementia, but not necessarily so. So we all have bad days. So how could we manage our finance on these bad days? So this is just the general space I am working on. My overall research question is, how can we improve fintech cognitive accessibility for older adults? So by cognitive accessibility, I am looking at accommodating the specific needs of age-related cognitive decline and to ensure ease of learning and use, to identify cognitive challenges and to remove barriers to processing information. So I have been engaging with people with or without dementia to co-create personas and scenarios and trying to design proof of concepts around this space. So I have conducted dyadic interviews with older adults and their family members, usually adult children. And I have engaged in interviews and focus groups with domain experts. For example, people working in senior and dementia care, people working in fintech, and of course also human-computer interaction, AI, and software engineer experts. So we have created 3 personas during the process, and I will just roughly go over them and to illustrate the diverse needs in this space. For example, this first persona, Ming, is experiencing normal aging. Like in Ming's own words, for me, it's important to be independent. So this persona highlights the tension between autonomy and privacy and security around online banking and digital payments. In this typical scenario, let's say if Ming receives a questionable text alert for a transaction and it's a bad day with his blood sugar, which makes him not seeing the smartphone screen very clearly. And if he has this kind of problematic transaction, it is not always the case that he would like to reach out to his family, because some of the spending histories he has probably involve surprise gifts and stuff. So he does not really want his family to know. So maybe in this case, the outer social circle would come to help, such as the staff at the local senior centers whom he knows well. So the question would be, how could future fintech support this kind of scenario and support users like me better? Our second persona is experiencing frustrating cognitive problems. In Beth's own words, due to long COVID, I went from being a vibrant middle-aged person to 92. So this persona illustrates the fluctuating cognitive concerns and also a complex financial management problems many older adults face, and the collaboration. For example, Beth would solely rely on paper statements, and but his husband probably have gone online, like overall. So the collaboration between them would involve the traditional paper-based material and also online banking, and how to make those two formats talk to each other, and how to keep both of them well informed of their personal and business finance management. So that is the trick here. Our last persona, Samuel, is living in a small town, not in large cities like our previous two. And Samuel is experiencing undiagnosed cognitive decline. But Samuel is very well aware of the AI development in recent years. In his own words, I want AI to know as little about me as possible, and I will feel much better talking to an AI that looks like a person. So these two statements probably looks conflicting, but overall, I think it points to the interesting area of AI literacy, and how do we present AI assistance in all kinds of technology, but in this case, in fintech. So building upon these personas and scenarios, we are moving on to build design concepts. So some of the avenues we are looking at, fluctuating and evolving cognitive needs, the tensions between autonomy, privacy, security, and complex financial management, so family or community collaboration in fintech. And I'm sure there's much more. So my next step, which is ongoing design workshops. And I am conducting these workshops in person in Vancouver, where I am at, or online via Zoom. So actually, this is very open, like to all everyone in Canada. So we are inviting older adults and their family members. They can join individually or join in pairs, and we will discuss these personas and scenarios, share our thoughts, and sketch some design concepts. And I think it will be a very fun process. So here is my email, and please reach out to me. So we really hope that our work can inspire holistic approaches to future fintech support, and we invite you to join the conversation and learn more about this project by contacting us. And I think I will pop up some of the study details and my email again in the chat after the presentation. Thank you.
That's terrific. Thank you so much, Carrie. And why don't you just leave that there for now, and then people can can scrape your email off if they need to. So I do see some questions in the chat. There are no questions in the Q&A at the moment, but a question for Carrie. Can you explain about personas for our audience? Why are they important in the design process?
Oh, wow, fantastic question. Thank you. Personas is widely used in human-computer interaction research, very specifically in user-centered design process, because we want to involve the users early on. It is not that we have a system and then we push it to the users to test it. Instead, we want to involve the users from the beginning of the design research. And also we want to capture different characteristics of this diverse user group. Meanwhile, we want to protect our participants' privacy and security. So talking around personas can mitigate some of the tension about talking about one's own finance situations. We want to create this comfortable and a safe space for everyone to engage and to express their thoughts freely. I hope that answers the question.
That's a great explanation, Carrie. Thank you so much. Another question for you. What do you hope to achieve with respect to these technology developments? They're asking what your dream scenario might be.
Oh, yeah. I would love for this project to lead to a proof of concept design, and with these concepts, we could start engaging with fintech professionals, practitioners, commercial banks, even a central bank with my ties to the Bank of Canada, so that we can influence the current fintech practice little by little. So I don't think that it will be a magical solution that everyone will start to use it next year this time. But these changes come slow. But I think it's really important to start the conversation and steer it in the direction that meets the needs of older adults and their families.
Carrie, no extra questions right now, but I have one. And I'm curious about how, you're designing things for older adults. And oftentimes what we find that if we use universal design principles right at the beginning, that we build applications and interfaces that are good for everybody, and not just for those who are technologically sort of literate. So because I have to admit, I know a number of young people who financially are probably, they struggle a little bit with these apps as well. So I'm curious if you have some thoughts about how universal design might be able to improve fintech applications for everyone.
Oh, wow. Thank you. That's a big question. Yes, I could totally relate. I think there's some misconception that as people grow older, as people who are exposed to technology more than their previous generations, age tech will not be needed. Like, well, people learn these technologies when they're young, so they won't have problems when they get old, which is really not true. I think everyone will have relatable stories about difficulties to keep up with technology, which usually is developed for younger generations. So even myself running into a lot of problems with emerging technologies. So I think age tech will always be an ongoing conversation, and the universal access or whatever universal design principles will need to be evolved throughout time. And that's why it will need everyone's input in the process.
That's a great and diplomatic response. We have a question in the Q&A. Your thoughts on AI personal assistants or agents supporting us in the marketplace, and I'm assuming in the fintech marketplace.
Yeah, I think it's already be put to use. It's just like auto correction on spelling. It is just like translation apps. Sometimes people see it, but not really realize, this is AI working in the background, giving me alerts or giving me financial management advice, or saying, oh, you spend more this month than last. So I think this really points to the AI literacy and the communication of AI presence to the users, not just to older adults, probably to everyone. So the presentation of AI, the personalization of AI, I think it's a huge research space. Yeah.
Terrific, thank you. And another question: will the design? Do you have any partnerships with banks?
Not ongoing, but I'm actively seeking.
All right, so get the word out. Okay, and we've got a question from Sabi Duthie. Will the design incorporate ways to avoid financial abuse?
Oh, fantastic question. Yes, it will. And actually, in the current literature, financial abuse, whether it's obvious or underlying, has been noted. And we are definitely looking into that. Thank you so much for pointing that out.
Thank you so much. Okay, so Carrie, that was a terrific presentation, and obviously lots of great comments about how wonderful this domain of research is, and people are encouraging. So that's fantastic. Okay, so at this point, after seeing Carrie's terrific presentation, I'm going to ask our second presenter, Farah, to share their screen in preparation for the second 10-minute presentation. Farah is a PhD candidate at the Institute of Health Policy Management and Evaluation at the University of Toronto. She's also working as a trial manager at Trinity College Dublin in her postdoctoral fellowship. And I just realized that my laptop has once again frozen on me, so hopefully I've got it back again. Okay, and as a postdoc and for her thesis, she explored the impact of telehealth use on the treatment burden experienced of patients with chronic conditions. So with that, I'm going to mute the very noisy background I have at the moment and hand over to you, Farah.
Thank you so much, Josephine, and thanks again for joining the session. I'm Farah, and today I'm going to talk a little bit more about in the health realm, but this is my PhD topic, and it's basically relies on what type of financial burden patients experience when they get diagnosed with chronic condition. And my interest was specifically how do we use health technologies to reduce this type of financial burden on patients and caregivers who has chronic condition and managing it at the moment. And my PhD supervisors are Dr. Carolyn Steele-Gray and Dr. Abib Shahak. So when patients first get diagnosed with chronic condition, there are so many costs associated with it. Like now they have to go see their doctors, and it can have like public transportation cost, fuel cost, parking cost. And also they might need to buy multiple different types of medication, buying health aids, sometimes home care services like PSWs. And then some of the services are still not OHIP covered, like even essential services like mental health counseling, having physiotherapist or occupational therapist. So, and also sometimes diet and exercise regimen get changed, which is basically when you have diabetes, you might need a whole new different types of diets. So all these types of prescriptions are really great for managing chronic condition, but it also accumulate over time and cost you a lot of money. So bottom line of this presentation is that being a chronic patient and being their caregivers, it's really expensive at the moment in our current health system. And when we talk about financial burden, what we mean is like any type of healthcare imposed cost on our patient population. So why is it bad and why is it important to talk about financial burden? When patients experience financial burden, they become non-adherent to the treatment protocol. What that means, they might skip medication, they might skip going to the doctors, and it's not really because they don't want to, it's beyond their capacity, it's beyond their budget, because a lot of people do live within a limited budget that they're living with. So they become non-adherent to the treatment protocol, and it's really not their fault. It's really a systematic failure that we don't talk about this kind of adherence enough. And when they become adherent and they start skipping the protocols, it can have like negative health outcomes and decreased quality of life. And paradoxically, now they need even more health care because the symptoms might have been complicated over time. And the doctors may have to intensify the treatment protocol even further. So that means even more medication, even more visits to the clinics. So it becomes almost like an endless cycle of a vicious cycle of high financial burden and poorer negative health outcomes. And this is especially important for people who experience societal inequity, like people with low income, low socioeconomic status, because they might not have the disposable income or capacity to shoulder this kind of burden. So my interest was that how do we use health technologies to relieve this kind of burden, and how do we intervene using the technological features that we have right now? So this study was conducted within Ontario, Canada. So a lot of examples might be more specific to Ontario. And this was a multi-method study. So first of all, when we talk about financial burden, who is most at risk of it? People who have multiple chronic conditions because they might need more medication and also more clinic visits, so that can add up. People who lives alone because they might not have, they might not be able to rely on another income. And people who don't have unpaid caregivers because sometimes they have to rely on paid services such as PSWs, which can have really high rate. And then people who live in rural and remote areas because sometimes they live very far away from the social and health services. To go to the services, it might have really high transportation cost. And then lastly, people who have low socioeconomic status, again, like people who are unemployed at the moment or have part-time jobs because sometimes they don't have the stable enough income to spend on their health. So when we think about financial burden, we really need to think about this patient population even more deeply. So then we conducted some empirical study. We surveyed 75 patients and across Ontario, and we saw that within the survey that people right now experience a moderate level of financial burden. So out of 10, they reported 5.62, which is still pretty high. So we then delved deeper into what are some factors that is contributing to this financial burden. First of all, insufficient OHIP coverage for home care services and allied health services, because sometimes people don't think it's medically necessary, so it doesn't get covered, or they don't have the insurance to cover it, so that can really add up. And secondly is like our workplace is still not very caregiver friendly. And so a lot of people might have to leave their job or take an early retirement just because being a caregiver can be a full-time job. And when you have two full-time jobs, it can be really, really hard to juggle both. And they can also miss all like promotional opportunities because they might not be able to engage with the workplace as much. So we really need a more caregiver-friendly policy, caregiving leave, so that they can engage with their work even more. This is especially problematic for younger caregivers because at the beginning of their career, their income potential or their growth potential can be stunted because of their dual roles, and they might need a really long time to catch up with their peers. So we really need to think about how we are supporting younger caregivers in our workplace. And thirdly, it's rural and remote Ontarians. Ontario is huge, but our services are very concentrated in the larger town, especially like specialist services like oncologists, dermatologists, those kind of things. People might have to travel very far, and it can cost them a lot of money. And more importantly, people have mobility issues. So because they might have to rely on accessible public transportation or accessible taxis, which is hard to get, which can be expensive or even rare in rural Ontario. So we really need to think about how this patient population can be benefited from technology. So what are some available evidence we have on how to use technology to support this sort of patient population? First of all, what we found is very optimistic. Virtual care platform, virtual support group, online education programs are really great to save money because there is no travel cost, and also they save some time, parking costs. So those are really great. And indirectly, also flexibility offered by these virtual programs also save people money because now for a 20 minutes appointment, they don't have to travel 2 hours to the closest town. So there is less crediting of like some people work hourly wage jobs. So sometimes they don't lose out on those things. And it's kind of helpful to schedule this in their work hours. But also, we also have to think about there's a flip side to it. When these kind of technologies require money, like people have to pay out of pocket. This is especially relevant for self-management devices or telemonitoring devices. So then it can increase patients' financial burden. And also some of the technologies require ongoing connection with high-speed internet. So buying internet is still very expensive in Canada. So we need to think about if those technologies actually increasing the financial burden on our patients. So I know in EPIC-AT, there are a lot of tech developers, implementers, and evaluators. So really the key takeaway message from this presentation would be what are some things to consider when we do develop this sort of technology. First of all, when we develop technology, we need to think about, is there any out-of-pocket cost associated with it? Because if there is, it might not be accessible for all, especially people who need it the most. So low socioeconomic status, people with multimorbidity and such. And secondly, is there a need for ongoing internet bandwidth, or what type of internet bandwidth this technology requires to use it? So one simple example would be audio versus video call. Video call requires a very strong internet bandwidth, and a lot of people might not have access to it. So they might not be able to engage it with it properly. So we really need to think about it. Secondly, when we implement this kind of technology in people's home, what kind of home environment do they have to set up this technology? Do they have access to a knowledgeable caregiver to really set it up for them? This is especially important for people with low digital literacy. And also people with low mobility issues. We have heard so many examples of that, people who use wheelchair in their apartment or in their house. Having one more cable can be really dangerous or hazardous. It can lead to trip and fall. It can cause a lot of anxiety. So maybe having a digital navigators or a technicians coming in and saying if this technology is safe to use in a home environment is really important. Thirdly, and lastly, in terms of evaluation, we have evaluated a lot how cost-effective technology is for our health system. But are we downloading too much work on our patients to take on through these technologies? We also need to think about it. Are financial burden relieved by technology use, which we saw there are some stuffs that actually get relieved by technology, but sometimes it can also add more work on our patients. So really to explore true value provided by technology, we really need to think about both patient side and also health system side. Is it saving money in the longer term? So at the end, this was my presentation, and thank you again for joining the session. And if you have any questions, I'm happy to answer.
Fantastic, Farah. Thank you so much. So interesting. And we do actually have a number of questions. Jill is asking from the Q&A, how many of the participants had applied for the disability tax credit?
So that was actually really interesting because for us, that was not a question we asked, but this was something they were rely on in a lot of cases because they have limited income, and that is something they were relying on at the moment.
Oh, interesting. Okay. Another question from the chat. Are there other jurisdictions that are better for older adults in Canada financially? And what can we learn or implement from some of those national or international examples?
So I think through our reviews, what we find that in Canada, we have a universal health coverage, which actually does help our patients a little. But for example, we have seen some examples from South Africa or US, United States, where there is no universal health coverage. So they're not actually doing so well as Canada. So we are a little bit ahead. But also there are better examples of Nordic countries or Scandinavia, where a lot of these technologies are built in their health system, or the allied health professionals are kind of covered by their health insurance. So in this kind of setting, it really depends on how much is covered by their health insurance. So I think in terms of that, within Canada, we don't have a comparative examples, but internationally, Canada is kind of in the middle.
Okay, interesting. Another question for you. What do you think about universal access to internet services? And is there a movement for this in Canada or elsewhere?
That's a great question. I think two of my takeaways is like to make health technologies work for all, two things is really important: universal basic income and universal internet. Both kind of goes on hand, because when we talk about the structural precarity, it's not really just internet, it also all the other types of societal barriers patients have. So having an income or would be really great. So I think, yeah, both should be there, both universal health, universal internet coverage, and also universal income. I think both should work at the same time. Sorry, Josephine,
I'm going to
you might
move
be
over
muted.
to Carrie. Farah, not sure if this was coming up as well, but the concept of HST exempt for GST for private pay, PSWs, when HCCS PSW support is in place, specific in Ontario, it's a good cost saving when piggybacking systems private and public. So I think they're looking at, they're actually, it looks like some sort of HST exemption associated with private pay PSWs. Is that something, and perhaps Karen, if you're out there, if you wanted to just perhaps give if you wanted to unmute, and perhaps if you can, give it a little more explanation if Farah needs more data, or are you comfortable responding, Farah?
A little bit explanation would be helpful. I'm not too sure, but as I have heard from our patients and caregivers, that cost can really add up. But yeah, a little bit more clarification would be good.
Karen, if you just wanted to pop something into the chat, that would be really helpful, because I think it would be a great, it's a great piece of information for us to perhaps discuss. Sam?
So Karen's here.
Josephine.
Yeah.
Hi.
Hi, thank you, Karen. Terrific.
Thanks for unmuting me. Sorry, I typed it wrong in my urgency to get it up there. It's HST exempt. So yeah, say you have somebody that is receiving the LIN PSW services, and then you bring in a private pay PSW in addition to that, you can get the HST exempt from the private pay cost. So if you could imagine, like if you have somebody requiring daytime support or 24-hour support due to whatever sort of medical situation they have, you might be getting bathing 3 times a week from the LIN PSW, but if you can have those cost savings, in line with having that private pay PSW, it adds up for sure. And I'm seeing in my role, it's something that's often missed by a lot of layers, like whether it's the PSW companies or the teams on the ground.
Okay, that's actually really good to know. And I think that kind of goes to Sam's question as well. One of our recommendation from our thesis is like having those kind of financial literacy program in primary care services would be so helpful, just because there are a lot of support out there our patients don't know about, or our caregivers don't know about. I didn't know about this either. So this was really a good example of how much financial literacy it's needed, and especially we don't need it only on the internet. We need to do it in the community where patients are.
Thank you. And we can actually come back to that and to Sam's question at the end. I'm afraid we're going to have to stop things right now. Again, we'll come back to your questions in the general session at the end. At this point, thank you, Farah, so much for a great conversation, and obviously one that many people are interested in. I'm going to move to our final Move the Dial presentation, which has been done by Chenny Xia from Gotcare. Gotcare is transforming how clients are connected to home health services. Their AI-driven platform seeks to find the perfect match for each client with the goal of increasing care consistency and continuity. Gotcare also provides wraparound services such as virtual visits and remote monitoring, so clients feel connected to them even when someone isn't in the home. As a social enterprise, Gotcare's goal is to make care more affordable. The team has been quietly piloting a new program called Gotcare at Cost, which can help families save up to 50% of their home care budget. So with that, Chenny, I'm going to ask you to share your screen if you'd like, and you have 10 minutes.
Amazing. Thank you. Let me just get this. Okay. Hi, everyone. Nice to meet you, and thanks for taking the time. Our brand promise at Gotcare is human contact within 30 minutes. So anytime anyone needs anything from us, you will have contact with someone from our team within 30 minutes. We are powered by a national network of 40,000 community care workers across the country. We operate everywhere except for Quebec and the northern provinces. As Josephine generously provided the introduction, we are an AI-enabled model of care. Our goal is to really expand upon the definition of what type of care can be provided in the home setting. As you know, internationally, there is a much more expanded model of home health than it is here in Canada. In terms of the AI technologies that we utilize specifically, we do provide matching when it comes to patients to providers. We also use AI for health biometrics and event monitoring as well. And we also look at population health using AI too. So just to kind of bring it to life for you, let's say you have a need in going to use Bancroft here as an example. Here's a map of our coverage in Bancroft, Ontario, and it shows you exactly how many care workers we have in that region. We're able to then provide in-home interventions. We're also able to provide virtual interventions. And then we also provide personalized safety devices as well. With that, it can be resources, reminders, or ability to contact members of the care circle, both health professionals and family. And really just, it's truly about how can we, again, expand upon the type of care that can be delivered right in the home setting. We also improve digital health equity as well. So our care workers in select rural communities do travel with satellite internet backpacks. So essentially they can activate a hotspot for the duration of their home visit. And a lot of what we are focused on is interoperability and enhancing that responsiveness. So really providing all the members of the circle of care that the client has consented that data sharing for, so that we can make real-time modifications to the care plan together as needed. Currently, Gotcare mostly delivers care with insurance funders. So we work with about 38 insurance funders today. What we've been able to demonstrate through this model of care is that we've been able to contain costs for our insurers. So going from a 97% utilization to a 67% utilization, because we are enhancing on our clients' abilities to self-manage and providing them with proper self-management tools. And it's also about reducing time to care. So going from up to 2 months between time of need to time of care being in the home with Gotcare can be as quick as next day. But we also acknowledge that there are a lot of people who, as mentioned by past presenters, earlier presenters today, that people just simply don't have access. Approximately almost a third of Canadians identify as family caregivers, and Canadians today spend about 5.7 billion in unpaid hours each year in caregiving. And so what we're piloting at Gotcare is essentially our services at cost. So you can save up to 50% on your home care for clients who do not have access to care. And as I showed earlier, we do match clients to care workers who live 15 minutes within their own home. So just some high-level overview for the pilot. So there does need to be a need for greater than 10 hours of a week of care. The client has to not have third-party funding currently for care, so they have to be without other pre-approved funding. And they do have to be willing to use simple technology. In terms of the process, the way it works is the client submits a care request on our website, assuming their eligibility, which we confirm. They sign a services agreement with us, and the client is provided a local care worker that they can work with, and the care workers actually pay directly from the family through a simple online interface. That's how we're able to provide the at-cost price. And it is subject to availability within certain regions. So basically any regions where we have a surplus of supply, we do offer care at cost as a way to enhance access for families who just don't have any. And yeah, and really for us, it's all about just the right level of care in the right location at the right time, faster access to that care, improved care continuity, and really just providing real-time visibility to everyone involved.
Wow, that's a really interesting program, Chenny. Thank you so much for sharing that. And you're a B Corp. Is that correct? Yeah. Perhaps you want to explain that to folks as well, so they can understand your business model.
Yeah, so we're a social enterprise, and what that means is that our corporate documents are structured as such that we are measured just as much by our impact and our impact metrics as we are our financial impact metrics. So it's really looking at your bottom line in a much more diverse way, and those impact drivers are typically based on your theory of change or your theory of transformation. So for us, it's all about driving increased access to services, but also in trying to address our health labor shortage. Because right now, as you know, being a frontline home care worker is not always a desirable job. And so we're working to create working conditions and employment opportunities by expanding on the type of work that they do and also creating new ways that they can get paid as a way of stabilizing this workforce. And so based on that, our investors and our stakeholders measure us based on those impact metrics related to our theory of change.
Really interesting. And I see that there is one question from Deborah. Are there financial assessments required for the pilot program? Does there have to be a caregiver involved?
Yeah, so basically the family has to be able to pay at the 25 per hour rate. And that's mostly just to protect our workers to make sure that there's that funding available. And no, actually we at this point, given the limited space of the pilot, we are giving preference to families who don't have any access to services. So they don't have insured services, they don't have LIN services, they just don't have that care. Also, it's not just for older adults, so it can be also for children with needs as well.
Terrific. Thank you so much. So at this point, I'd really like to throw the floor open to other folks. We have Carrie here, we have Farah here. So if anybody has any questions that they'd like to ask of anybody, please do so. I am going to ask one question. And I'm so sorry, I have a situation. You're going to hear a little noise in the background. I apologize. I think that there was a question at one point and it came from Sam. And Sam, did you want to repeat your question? I think it was for Farah.
I'll see if I can get Sam up. She's not on the line right now.
Oh, she's okay. That's all right. I had seen her question there, so I think that was. And I think Deborah had also asked. I think it was a Farah. Do you have to already be receiving some LIN care?
So in terms of Sam's question, I think yeah, our first two recommendation was really that when we develop technology, we need to be mindful about, is it accessible for people in terms of do they have to pay extra money to buy these devices? So it might be better if we try to use the devices patients already have, because a lot of people now have a smartphone, a lot of people does have computers. So having those existing devices might be really helpful. And secondly, we also really need to think about how much internet technology use, just because I feel like a lot of the time, because when we're in our ivory tower, we don't think about, a lot of people don't have this kind of internet accessibility. So with these two things, we really need to think about. And in terms of LIN program, I think it's coming from the PSW questions, like if they not 100% sure, but in terms of yeah, most of the patients are within some sort of LIN, as far as I know, in Ontario, and they can access to PSWs or home care services through those. I don't know if it answers the question.
No, that's terrific. Thank you. I guess I really love this final question everybody has asked here. And the bottom is, what are your hopes for the future of age tech and particularly in your field? And I think, Carrie, we asked you at one point, where would you like the technology to be and where do you think it should be? And I'm just curious of whether any of you have any concerns or thoughts about that.
Yeah, so I think it's very easy for us to add technology and stir. And one of the things that we've learned is that when we deploy in a new community, we have to co-create with all the different stakeholders in that community. Like, let's be honest, many healthcare providers still operate mostly on fax as their main source of communication. And so I think when we think about technology implementations, we have to think about ourselves as not just technologists, but also change management experts. And so with that lens, I think it begs us to look at our work differently and resource our teams differently. So for example, at Gotcare, whenever we deploy in a new region, we set up open co-creation sessions where we invite a very diverse stakeholder list and people can come. They also know when we have open town halls where they can join in calls and hear what's going on and updates. It's really just having that two-way communication that's constantly open, I feel like is a really strong driver of trust. And if we don't have trust, then we can't implement any of this.
That's so true, isn't it? The socio-technical piece, it's so much more about the socio than the technical when it comes to getting people to adopt and use it more frequently. Carrie, you were going to, I think, jump in.
Oh, thank you. Yes, I really echo Chenny's point there, because in my research, people often talked about the two-factor authentication. I think everyone is familiar with that when you try to do some kind of the banking stuff, but sometimes older adults are not very familiar with, let's say, online banking. If they want to activate something, they saw that job was done, so they closed the web page and then they received the text. So that doesn't match, right? And then they open another one and then they have to activate a two-factor authentication again, and it didn't go through. So, and they might also have a lot of phone numbers. You don't know which one is this bank on their record. And sometimes you can use email, but again, email that just adds another layer of technical hurdle. So I think we all trying to do something good here. We want to make everything safe, but in this process, there's really a lot to think about. So stakeholder engagement is a really paramount step here.
Yeah, and to your point before, I guess technology is developing and adapting so quickly that those people who may be literate now and digitally competent now could be equally as strapped as new technology comes online. So really important. Farah, I'm going to give you the last word here. Do you have any other any suggestions as well for the that best case scenario?
Yeah, no, I think socio-technical piece is so important. I think one thing I really hope to see that when we are putting in technologies in patients' home or in the community, we really need to think more about the patients and how much, what type of work it's putting on. So a little bit more sociological lens on technology and moving from just technical side to socio side. I think that's my hope for the future.
That's terrific. Okay. All right. It is now time for me to say thank you to all of our wonderful presenters. And in the chat, everybody has been echoing exactly the same thing. Fantastic presentations. I'm a bit biased. This is my area of interest and expertise as well. So I'm delighted that we had such wonderful presentations today. As Alison has prepared some notes, she said this has been a truly epic 2 weeks. And she wanted to just say, thank you to all the 32 presenters, the grad students, postdocs, research staff, and stakeholders with lived experience for taking the time to share their exciting and collaborative work with us over the last 2 weeks. We are equally thrilled with the leadership of the 8 challenge area session chairs. Thank you so much for sharing your time and your expertise. This year, as you likely know, we were excited to introduce a new segment called Moving the Dial, thank you, Chenny, that highlighted the work of 8 AGE-WELL partners and supported startups. We thank these presenters for showing us that making our real-world impact is possible. Shout out across the Move the Dial folks to Able Innovations, Best Buy Health, Gerastance, Gotcare, Hippocamera, Imagi-Able, Action, Independence Mobility Inc., and Root and Seed. Over the last 2 weeks, we've been joined by over 1,000 viewers from 25 countries on 6 continents and counting. So if you're looking to get some international exposure, consider yourself ticking that box. And this didn't include the sessions that we put up on YouTube. The continued support for the EPIC conference, the largest global trainee conference in age tech, and the keen interest in AGE-WELL's work highlights to us just how vital your work is, and we want it to continue. So we were thrilled to see so many participants also from government, industry, and community stakeholders. So you have a very wide and diverse group of people out there. The EPIC training program supports over 1,400 graduate students, postdoc fellows, research staff, early career researchers, and EPIC-AT fellows across Canada. These individuals receive both financial support and access to value-added programming on everything from ethics to entrepreneurship, stakeholder engagement to the policy research dynamic. Most importantly, AGE-WELL supports these trainees to contribute to practical solutions that will have real-world impact. After attending the EPIC presentations over the last 2 weeks, I'm really confident in saying that the future of age tech is really, really bright. So, merci encore de votre présence et bonne journée. And thank you again for attending, and have a wonderful rest of the day. Thank you so much, everybody. And we'll see you again next year. Bye.